Okay, in this video, we will be discussing about the pain. I mean, this is a reading from the Harrison. I will be reading the chapter from the Harrison's textbook, 21st edition. I will be focusing on the important lines, important parts of the paragraphs, the important concepts which are vaguely distributed in the chapters throughout the book. So as far as first unit and first chapter of the first unit is concerned, the chapter is pain pathophysiology and management. Right, this is chapter on the pain, the sensory system, the the peripheral mechanisms, and the pain modulation, and how to treat acute or chronic pain. So that is all about pain, that how it is generated, how it is conducted, how it is perceived, and how it is modulated, and what other important parts that are there to be discussed in this chapter. So there are 5 to 6 pages in this chapter. Let us review them in the starting itself. The first topic is this. Uh, what do you call it? The first topic is this pain sensory system. Right. In pain sensory system, there is peripheral mechanisms and their subtopics. Then central mechanisms are there. Then pain modulation, how the pain is modulated. Right. Neuropathic pain, there is a dedicated paragraph for neuropathic pain, and then treatment of this acute pain, right? Then there is chronic pain also, but we will not be discussing this chronic pain in this video. I will be discussing, or I will be reading chronic pain in the subsequent videos in future. So starting with reading with the pain pathophysiology and management, let me zoom in for better understanding. Pain pathophysiology and management. They say the province of medicine is to preserve and restore health, to relieve suffering, and pain is the most common symptom that brings a patient to a physician's attention. Right? Pain is the most common symptom in the OP or whatever. Pain is the most common symptom with which the patient presents to the doctor. Sensory system, the pain sensory system. It is generated, it is conducted, and it is perceived by the brain. First is the peripheral mechanisms, how the pain is generated. The primary efferent nociceptor. Nociceptor is the pain receptor. Pain is some stimulus which causes unpleasant reception, unpleasant situation. That is pain. That is the stimulus that causes pain. Primary efferent nociceptors. A peripheral nerve consists of the axons of three different types of neurons: primary sensory efferent motor neurons and sympathetic postganglionic neurons. The cell bodies of primary sensory efferents are located in the dorsal root ganglia. We are very much well versed with this concept within the vertebral foramina. The primary efferent axon has two branches. One projects centrally to the cord and the other projects peripherally to innervate the tissues. Right, here it is the dorsal root ganglion. It has two branches. One is to the nociceptor, the second is to the spinal cord. Here it is the cell body. It has two axons. I mean, the axon is bidirectional in here. That is all that is written in here. The largest fiber is A beta. It responds to mild touch, and the other is the A delta and the unmyelinated. See, these two fibers are small fibers. See, A delta is myelinated and small, and C fibers are unmyelinated. Both of these are small. A delta is small myelinated and C is small unmyelinated. Right? So this is written in here: myelinated A delta and unmyelinated C. Both these are sensory, and both of them they carry uh, pain and temperature. These fibers are present in nerves to the skin and to the deep somatic and visceral structures. Some tissues such as cornea are innervated only by A, delta and C. These are the exceptions. We do not need to remember them as of now, right? Then most A, delta and C fiber afferents respond maximally to intense painful stimuli and produce the subjective experience of pain when they are activated. This defines them as primary afferent nociceptors or pain receptors, right? Pain receptors. Individual primary afferent nociceptors can respond to several different types of noxious stimuli: cold, mechanical distortion, pinch. So these are all the stimuli to which these nociceptors they respond. There is another channel subfamily TRP1 known as the vanilloid receptor. It is very important to remember, by the way, because in NEET PG there has been a question on this TRP1 channel many a times. Nociceptive neurons activated by heat, right? They are sensitive to heat, acidic pH, capsaicin. So these three are the stimuli for TRPV1. We must not forget them: heat, acidic pH, and capsaicin. Now this next topic is sensitization. It is very important topic because a question has been asked from this topic a number of times in NEET PG as well as in NEET SS also. They say when intense, repeated or prolonged stimuli are applied to damaged or inflamed tissues. See, damaged or inflamed tissue is a prerequisite. When stimulus is applied repeatedly to these tissues, the threshold is lowered, frequency of firing increases, and relatively lesser stimuli produces more pain. This is called as sensitization. Relatively lesser amount of stimulus produces more pain. It is called sensitization. The question exactly was asked: where sensitization happens? What is the site of sensitization? Sensitization occurs at the level of peripheral nerve or at the level of dorsal horn of the spinal cord. I mean, in the spinal cord itself. Here it happens. Here happens sensitization, or at the level of peripheral nerve. This is the peripheral nerve. Here it will happen. This is dorsal root ganglia. This is peripheral nerve. Here will happen sensitization. Here will happen sensitization. These two are the sites of sensitization, right? Then there is a term alodynia, means the stimulus which is not noxious otherwise is perceived as noxious. It happens in some peripheral neuropathies or peripheral nerve damage or some damage to some tissues. So alodynia can occur. For example, a breeze, a wave of breeze may initiate severe pain in trigeminal neuralgia, right? When breeze touches your face, you experience a hell amount of pain. It occurs in trigeminal neuralgia. It is called as allodynia. Right. Then they have told us about the referred pain. No, this is not referred pain. This is basically silent nociceptors. They say in normal, there are some receptors in the viscera, means in your organs. The receptors are there, but they do not respond to pain. They do not perceive pain in normal situations, but in the times of injury, in the times of damage to those organs, those receptors start relaying the pain, right? So that is why these receptors are called as silent nociceptors. That is all that is given in this paragraph. Nociceptor induced inflammation, that is another topic. C gene related peptide, cholecystokinin are involved in this, right? Substance P. We have understood the peripheral mechanisms of pain generation and transmission. Now we will come on to the central mechanisms. The spinal cord and referred pain, very important. See, what is referred pain? Basically, we have to understand the spinal cord first of all. Where is spinal cord? Yes, this is spinal cord. This is a segment of the spinal cord, right? Suppose this is segment C5 of spinal cord, and it carries impulses from uh, diaphragm. We have understood that there are different types of nerve fibers, A delta, C fiber, right? These fibers will carry the uh, stimulus from the skin as well as from the viscera, right? And they will project onto the same spinal cord segment, right here, not right here. They will, I mean, this is the spinal segment C5, and here is the second order neuron. It will reach the opposite side. The pain from the skin and pain from the viscera, though they are carried by different fibers, but they project on a single fiber, right? And this single fiber, it will carry pain to the opposite side thalamus, contralateral, contralateral carrying of pain. Now suppose if if the damage is in the skin, you will perceive the same pain. I mean the pain at the same site. If the pain is not in the skin but pain is in the viscera, you will perceive the pain in the skin also. That is the referred pain, right? This is because of the same segment involved in the transmission of the pain. Let us see what is written in Harrison. The major neurotransmitter released is glutamate, right? Glutamate, uh, which rapidly excites the second order dorsal horn neurons, substance P and C gene related peptide. Thus, a convergence of secondary inputs to a single spinal pain transmission neuron is of great importance because it underlines the phenomenon of referred pain. Right, pain is mislocalized by the patient to a bodily location that roughly corresponds to the region of skin innervated by the same spinal segment. Spinal segment is same, that is why the pain that is carried to that segment from anywhere from the skin or the organ will be perceived as referred pain. Means the pain will be in the viscera, but it will be perceived as if it comes from the skin. For example, if the pain is in the diaphragm, it will be perceived that it comes from the shoulder, because shoulder and diaphragm are supplied by the nerves that converge on the same spinal segment, that is C5. That is why the pain from the diaphragm will be perceived as if the pain is coming from the shoulder. Ascending pathways for pain. Right. Pain ascending pathways are, the pain is carried from the peripheral nerves. It it is carried by the dorsal root ganglion cell, and it is relayed onto the second order neurons in the dorsal horn of the spinal cord. From dorsal horn, the the fibers will, they will cross to the opposite side, and from opposite side they will ascend upwards to the thalamus and cortex, right? It is written that our thalamic neurons project to the cortical regions from thalamus to cortex that are linked to emotional responses such as cingulate and insular cortex, right? So the pain from thalamus will be relayed to the cingulate and insular cortex, as well as to the cortex, to the somatosensory cortex. Somatosensory cortex will perceive the amount of the pain, and cingulate and insular cortex will initiate the emotional responses. So that is why there is a fear associated with the pain. It is a constant companion of pain, right? This is the referred pain. From viscous, the pain is carried to the same segment. From skin, the pain is carried to the same segment. So that is why if the injury is in the viscous, it will be perceived as if it is from the skin because same neuron is activated. Pain modulation. They say कि injuries of similar magnitude they produce remarkably variable pain. Right? Pain is produced in different magnitude by similar stimuli. How is it possible? It is possible because of some interneurons and modulatory pathways. We will see it in a few minutes. Okay. They say there is a placebo effect. Means if I have taken a medicine, I will somehow believe that it will cure me. That is placebo effect. And if I have a sharp object, for example, if I am undergoing a uh, if I have to take some injection, right? If doctor is trying to apply me an injection, I will perceive an enhanced amount of pain, right? I will perceive more amount of pain which will be out of proportion to the amount of the stimulus applied. For example, the doctor is making his syringe ready to give me the injection, but I will start perceiving a hell amount of fear and pain even before he puts the injection into me. So that is the nocebo effect. uh, it is also explained by the brain circuits, right? Hypothalamus, midbrain, medulla, it is all involved in that process. Human brain imaging have implicated this pain modulating circuit in pain relieving effects of attention, suggestion, and opioid analgesic medicines. Right? They say if someone is undergoing pain and you divert his or her attention from the pain, how will you divert the attention? You will divert the attention with the help of uh, some strong emotion. For example, in a situation of war or an athlete just before the competition, his attention is totally diverted from the pain producing stimulus, and he will forget pain, though the amount of the stimulus of pain is of considerable strength, but still he will not be able to perceive pain because his attention is diverted. So that is also explained by some brain circuits. And opioids, endogenous opioids, they also try to suppress the pain. So that is all a part of pain modulation. If exactly we try to understand that how pain modulation occurs, they say pain modulation occurs from the thalamus, from the cortex. First of all, we must understand how the pain is transmitted. Pain is transmitted dorsal root ganglion, then to the dorsal horn of spinal cord, then to the opposite side, then to the medulla, then to the pons, then to the thalamus. From thalamus to the insular cortex, from thalamus to the frontal cortex, from thalamus to some other cortical areas. So these are all the pain sensing pathways. Now what happens that an interneuron starting from the cortex, it will project down in the midbrain. From midbrain it will project down to the medulla. From medulla it will project down to the dorsal horn. Here is where action happens. Here is where modulation happens. Signal is coming from cortex, but it is acting at this uh, dorsal horn to reduce the pain. It will reduce the pain by secreting endogenous opioids in here. This is the pain modulation, right? If we do a functional MRI, we will see various uh, areas of the brain involved. First is the dorsolateral prefrontal cortex, DLPFC. Then is the rostral anterior cingulate cortex, periaqueductal gray, and rostral ventral medulla. These are the areas which are involved in pain modulation. Right, intense emotion directed away from the pain causing injury during severe threat or an athletic competition. Right. So, as far as neuropathic pain is concerned, this is the kind of pain which is originated when there is injury to the pain conducting pathways like nerves and the thalamus. We know that the sensory nerves, they relay at the thalamus. So whenever there is injury at the level of nerve or at the level of thalamus, it will cause a certain characteristic pain, which is burning, tingling, or electric shock like, and it is resistant to standard treatments for pain. Right, let me highlight it. It is resistant to standard treatments for pain. It is called as neuropathic pain. So neuropathic pain is associated with hyperpathia and allodynia also. Right. So that is all about the neuropathic pain. Neuropathic pain is is treatable with some anticonvulsant drugs like carbamazepine, valproate, gabapentin, pregabalin, etc. But this kind of pain respond poorly to aspirin, uh, to diclofenac, naproxen, ketorolac, etc. Means NSAIDs, opioids will not work. Only anticonvulsants will work. Then sympathetically maintained pain. We know that sympathetic nerve supply is also there to all the organs of the body. Whenever there is injury to some somatic sensory nerves, right? Somatic sensory nerves. What happens is that there is sympathetic overactivity at that time. Let me try to explain to you with the help of some image. We know that there is this sympathetic supply to the organ also. But these are the sensory fibers, A delta and C. And C, these two are the sensory fibers, means they will carry pain and temperature. And this fiber will carry out the sympathetic and parasympathetic functions. For example, sweating, for example, vasoconstriction, vasodilation, etc. They say whenever there is injury to these nerves, this nerve gets hyperactive. And because of its hyperactivity, there will be swelling, periarticular bone loss, there will be joint deformity distal to the site of injury. Right, this is known as CRPS, complex regional pain syndrome. Right, this is the CRPS, complex regional pain syndrome, CRPS. Two types. Type 2, when there is post-traumatic neuralgia or causalgia, means there is nerve injury. That is why there is a cause underlying this CRPS2 and it is known as causalgia. But its analog is CRP1, CRPS1. It is known as reflex sympathetic dystrophy. There is no underlying, no obvious, without obvious nerve injury, CRPS1. Effect is same, swelling of the joint, swelling of the limb distal to the injury, periarticular bone loss, and joint deformity. Right. We can treat it by blocking the sympathetic nervous system. Otherwise, there is no treatment for CRPS. Right. It is very crippling kind of disease. It occurs in Colles fracture, in trauma to some joint, or all these are the uh, causes. Here it is written myocardial infarction also, it is also a cause of CRPS. So this is a sympathetically mediated pain. It is not the classical pain, it is not the neuropathic pain, it is the sympathetic pain. Right. Treatment for acute pain is NSAIDs, first of all, first line. Second line is opioids. Now we will try to understand the NSAIDs. These are non-narcotic. Acetaminophen, ibuprofen, naproxen, ketorolac, celecoxib. These are the, and indomethacin, very useful in headache, some kind of headaches. These are the what do you call, classically used NSAIDs. Then these are the opioids: codeine, oxycodone, morphine, methadone, mepridine, butorphanol, and buprenorphine. Fentanyl also, tramadol, very commonly used in OPDs. So these are the opioids uh, which can be used in uh, pain. Though there is always, we use a combination of aspirin or acetaminophen plus an opioid. it was used extensively previously, but nowadays it is lesser used because of the repeat increased dose that we need with the opioids. So that may inadvertently lead to the NSAID overdose. So the combination is avoided nowadays, but it can be combined under if you are monitoring the patient to good with a good frequency. You are monitoring the patient, you can combine the opioids and analgesics, but otherwise you have to give opioids separately and analgesics separately, step by step. First of all an NSAIDs, then you will have to give opioids. Side effect of opioids is that it is addictive, but it is, you know, overemphasized. Its addiction is overemphasized. Let us see. Opioid related side effects can be opioid related side effects can be reversed rapidly with the narcotic antagonist naloxone, right? Very small chance of patients becoming addicted to narcotics as a result of their appropriate medical use. Most of the commercially available opioid analgesics act at the same opioid receptor. Receptor used is mu, and they differ in potency, onset of action, duration of action, and route of administration. There are some opioids that can be given intrathecally or epidurally, and we infuse them through a spinal catheter. So that is all. In this paragraph, it is opioid and COX inhibitor combination use. It We have additive effects, but side effects are very less. Can be combined, but usually not combined nowadays. Then is the chronic pain. We are not going to discuss chronic pain in this video. We will be carrying out this chronic pain in some other video. So that is all about this video. Thank you so much for your patient listening.